patient underwent high-dose melphalan followed by autologous hematopoietic cell transplantation. He was in a complete response at day 100, but remains positive on flow at a sensitivity of 10 power minus 5, the MRD positive. And currently, the patient is undergoing maintenance treatment. The PET-CT has shown almost complete resolution of the lymphadenopathy in the lymphadenopathy, which were actually plasmacytomas. And overall, the patient is symptomatically much improved and remains on single-agent lenalidomide maintenance at this time. So with this background, we will go into T1114 in newly diagnosed multiple myeloma predominantly. And what is the data that we have regarding how it presents differently from other patients with myeloma and any differential impact of treatment on T1114. So this is a paper by Dr. Rajkumar that was published a few years ago in Blood Cancer Journal that I really like, because in this paper, the authors divided cytogenetic abnormalities into primary and secondary cytogenetic abnormalities, which is a really good framework to think about a patient with newly diagnosed myeloma when we are interpreting the FISH abnormalities. So the primary cytogenetic abnormalities in myeloma can be of two different kinds. One is hyperdiploidy, which as we know is very common, and the second is chromosome 14 translocation. And in chromosome 14 translocation, we can have T1114, 414, 1416, 1420, and very rarely T614, which is not usually checked routinely at all institutions. And the secondary cytogenetic abnormalities typically include chromosome 1 abnormality and deletion 17p. There have been some other secondary cytogenetic abnormalities that have been discovered lately, including MYC translocations, which we can sometimes see in patients and usually predicts for an aggressive disease course. So T1114 is a primary cytogenetic abnormality in multiple myeloma. And what that means is that it's present in the founder clone, that even at the MGUS or the smoldering myeloma stage, we can see T1114, whereas it will be very, very unusual to see a secondary cytogenetic abnormality very early. So T1114 by itself it's not diagnostic of myeloma. It can be present in MGUS or smoldering myeloma stage as well. So going into the prognostic impact of T1114, so one of the first case reports or case series of T1114 myeloma was presented by Dr. Fonseca. As you can see, it's a very old paper in 1980s and 1990s, and the other one was by Chen et al. And in these papers, primarily T1114 was identified with conventional cytogenetics, not FISH. And an important caveat is that in patients with multiple myeloma, only about 30% of patients have positive have positive findings on conventional cytogenetics or karyotype at diagnosis, because plasma cells are not very proliferative in general. So if you are seeing any abnormality, be it T1114, be it hyperdiploidy on conventional cytogenetics or karyotype, it usually means that the plasma cells have a high proliferative index, and it can be considered as a high risk, irrespective of what abnormality we are seeing. So these were one of the two papers in which T1114 was initially identified on conventional cytogenetics. And as you can see, there was a wide variation in incidence across studies, from about 5% to 40%. Again, the reason being, what kind of patients were they testing? Was it the patients who had an extremely proliferative myeloma or not? That definitely played into the incidence of T1114 on conventional cytogenetics. And some of these reports actually showed adverse prognostic impact of T1114 on survival at that time. It also, they looked at the morphology of T1114. And in the first slide, you can see the plasma cells with scanned cytoplasm and lymphoplasmacytoid features, which is a typical feature of T1114 myeloma. And in the second slide, there's a strong nuclear positivity for cyclin D1 immunohistochemistry. And cyclin D1 is actually used as a surrogate for T1114 in many labs. We usually perform T1114 in our lab, even if patient is cyclin D1 positive. But if there is strong cyclin D1 positivity, that highly correlates with T1114 positivity in case the FISH is not available for a patient. Subsequently, Dr. Fonseca, along with others, they actually led the description of T1114 on FISH abnormality, on interface FISH in patients with myeloma. And the first study to comprehensively characterize T1114 on FISH was an old ECOG study, the E9486, which was in the chemotherapy era. So as you can see, they compared multi-agent chemotherapy VBMCP versus VBMPC plus interferon alpha versus VBMCP plus high-dose cyclophosphamide. Most of these regimens actually not even in use. And they wanted to look at what is the prognostic impact of T1114 in the era of conventional cytogenetics. They had some important findings. So they showed using FISH that T1114 leads to juxtaposition of the IGH enhancer in chromosome 14q next to cyclin D1 on chromosome 11q. And the incidence in newly diagnosed myeloma was 16%, 1/6. Now it's important because we don't usually think about it, but T1114 actually is the most common translocation in multiple myeloma. All the other translocations, including T414, T1416, and T1420, are much rarer. So after T1114 would be T414, which would be the next most common. But T1114 definitely is the most common translocation in multiple myeloma when tested using interface FISH. So they also discovered some unique clinical features. So they found that patients with T1114 myeloma, there were more patients in less than 40-year age group. And I really wanted to bring this up because when I talk to my colleagues in India, I hear that you see a lot of patients with myeloma in a younger age group, which is very unusual because in the US, our median age, as you know, in the literature is about 69 years. I mean, I can count a handful of patients, typically in single digit maybe, who are less than 40 years in my clinic. So that it would be interesting to see whether there is an increased prevalence of T1114 in certain populations, especially in which patients are presenting at a younger age. Then second, they found that patients with T1114 myeloma usually have a low serum M protein. M protein of less than 1 gram per deciliter is much higher, about double in patients with T1114 myeloma compared to non-T1114 myeloma. That is, they usually have an oligosecretory phenotype. They were not more likely to have a higher circulating plasma cells. And it's interesting because we know that T1114 is very prevalent in plasma cell leukemia, but when present in myeloma, they were not likely to have higher circulating plasma cells. And this has now been confirmed even with high sensitivity flow cytometry techniques that T1114 patients with myeloma usually do not have a higher burden of circulating plasma cells. They were obviously less likely to have hyperdiploidy because the hyperdiploidy is the other primary cytogenetic abnormality. And although they are not completely mutually exclusive, but we typically see more patients, most patients who have hyperdiploidy, they don't have chromosome 14 translocation and vice versa. And there was also a trend towards a lower plasma cell labeling index, which is a test not widely available, but is usually done at Mayo Clinic. And it basically tells us what percentage of plasma cells are in the S phase of the cell cycle. Again, the proliferative phenotype. And they found that patients with T1114 had a lower plasma cell labeling index. So in this study, as you can see, they showed that patients with T1114, they had similar progression-free survival and overall survival, and this was a very, very long follow-up, more than 10 years of follow-up, had a similar progression-free survival and overall survival compared to patients without T1114. So basically, they showed that although in conventional karyotype, when they were detecting T1114, it had an adverse prognostic impact. When T1114 was being detected by interface FISH, there was no adverse prognostic impact. So it basically depends how you're detecting it. And similarly, another cytogenetic abnormality, for example, deletion 13q, also had a similar story that initially when it was detected on conventional karyotype, it was thought to have a negative prognostic impact, but subsequent studies in which it was detected by FISH abnormality, there was no adverse prognostic impact. After that, Dr. Maury Gertz from Mayo Clinic in 2005 presented a large series of patients looking at the prognostic impact of chromosome 14 translocations in patients who had autologous transplant. So this study was only in patients with autologous transplant. It's important to keep that as a caveat because many patients who achieve a poor response to induction therapy, for example, or had rapid disease progression upfront, they may not be able to get to autologous transplant. So that's an important caveat to remember. Now, also in this study, Dr. Gertz showed that patients with T1114 did not have an adverse prognostic impact. But as you can see on the right side of the screen, patients with T414 or TP53 deletion, they did have an adverse prognostic impact, which is what we would expect because those are high-risk cytogenetic abnormalities. So basically, those high-risk abnormalities, T414 or TP53, they had an adverse prognostic impact even when detected by FISH, but T1114 did not. Now, this is a very interesting study from the Arkansas group. Let me remove this a little bit because it's interfering with the, okay, sorry. So very interesting study from the Arkansas group showing that maybe all T1114 are not created equally. So in Arkansas, they have been doing this gene expression profiling for a very, very long time. And they have shown early on that T1114 is typically characterized by two distinct subtypes, CD1 and CD2. And a CD2 patients usually are T1114 positive and also have B cell markers positive. For example, CD20 positive, like our patient, and also PAX5 positive. And if you see on the right side of the screen, this is the cumulative incidence of achieving a complete response or CR. And patients with CD1 and CD2, they were vastly divergent. Those who had CD1 T1114, they had a really high incidence of achieving CR in the context of total therapy protocols with tandem transplant, whereas CD2 had a very low incidence of achieving CR. Now, just based on this figure, you would expect that maybe CD2 patients don't do as well, but they showed below that actually, if you look at the progression-free survival, CD2 patients actually did pretty well despite not being able to achieve CR. And also they showed two important findings here. So their main question here was that whether addition of proteasome inhibitor or immunomodulatory drug will differentially impact these subtypes. And they showed that the green bar is the bortezomib, that on addition of bortezomib did not really help patients with CD2. But the addition of thalidomide, at that time, thalidomide was the only IMiD that was being used, did benefit patients with CD2. So basically, the message of the paper was, and there was also a recent paper showing that CD2 patients have a low incidence of MRD negativity. The message of these two papers were that CD2 patients with T1114, they have a lower complete response rate, have a low MRD negativity rate, but have a similar or maybe even better PFS and OS compared to the CD1 or other subtypes of myeloma. That is, they do well despite being MRD positive after therapy. Now, whether this holds currently in the era of quadruplet induction, for example, DARA-VRD or DARA-KRD induction, we don't know. We don't have the data on how T1114 patients perform in the era of daratumumab or isatuximab-based quadruplet induction treatment, but it would be an important question to answer. And also it highlights an important feature here that patients with CD2 subtype, if our goal in those patients is to achieve MRD negativity, they might be overtreated because they might do really well despite being MRD positive. The problem is we don't have any standardized or FDA-approved test to identify which patients are CD2. So currently how I interpret this data in my practice is patients who are T1114 positive, and if they have CD20 positive, I sometimes also ask the pathologist to do PAX5. And if their B cell markers are positive, usually that we can use as a surrogate that those patients might be CD2. And that gives reassurance that even if those patients do not achieve an MRD negativity, maybe they will have a reasonably good outcome in the long run. So the question is that what is the natural history of T1114 myeloma in the era of proteasome inhibitors and immunomodulatory drugs? Because all the data that I've showed you till now, they were mostly in the era prior to the introduction of PIs and IMiDs in our armamentarium. So to that end, Dr. Arjun Lakshman, who is at Mayo Clinic now, he did this study with Dr. Shaji Kumar. It was a really interesting study looking at the natural history of T1114 in the era of PI and IMiD-based induction. Excuse me. So in this study, they looked at 365 patients with T1114, among which 132 patients 365 with T1114, 132 without T1114 translocations, that is with high-risk translocations, for example, T414, 1416, or 1420, and about 600 patients with no translocations, that is mostly hyperdiploidy. So had a very large data set of patients. And almost all the patients got PI or IMiD-based induction, but important to note that a triplet or PI plus IMiD-based induction was only received in about 15% of patients because of the timeline of the study. And approximately 60% received high-dose melphalan autologous transplant as a part of upfront treatment. Now, they found some interesting clinical features of T1114. For example, those with T1114 had a higher incidence of pathologic fractures at diagnosis. About 20% versus 8% had a lower M spike at diagnosis, again, similar to the prior studies. That is, these patients are more enriched in oligosecretory or sometimes even a non-secretory phenotype, had a less ISS stage 3 disease at diagnosis. Importantly, higher incidence of light chain only myeloma. And this we see a lot in our clinic, that patients who present with light chain only myeloma and cast nephropathy, they have a high incidence of T1114. And these patients, important to remember that they do not respond well to bortezomib-based treatment. So it's important to incorporate anti-CD38 antibodies early on in these patients to be able to reverse the renal dysfunction. They have a lower incidence of deletion 17p, almost half. lower incidence of deletion 13q. And in this study, they did not have data on 1q abnormalities in a lot of patients, only 28. But of those 28 patients, none had 1q abnormality. So basically, in summary, a lower incidence of high-risk cytogenetic abnormalities in patients who had T1114. But the only, I would say, the high-risk clinical phenotype is that many of them had light chain only myeloma and hence presented with CAS nephropathy and high creatinine. So in this study, as you can see, they looked at the prognostic impact of these three subgroups. One was no translocation, that is mostly standard risk patients with hyperdiploidy alone. One was T1114, and the third one was non-T1114 translocation, that is the high-risk translocations. And they did this analysis after excluding patients with deletion 17p, who of course can be distributed equally in these three groups, so as to avoid the confounding impact of deletion 17p as a high-risk abnormality. And in all these three curves, the progression-free survival curve, time to next treatment curve, and the overall survival curve, you can see that T1114 behaved as an intermediate risk. That is, the outcomes were worse compared to standard risk myeloma, but better compared to high risk myeloma. And it's very important because, in the past, before the introduction of PIs and IMiDs, you had seen that T1114 had similar PFS and OS compared to non-T1114. So the question is, did the outcome of T1114 patients got worse with the introduction of PIs and IMiDs? So that's an important question because T1114, we know that they are less sensitive to bortezomib based on the Orcanstar data. So, that might mean that maybe we should incorporate some cytotoxic chemotherapies or upfront autologous transplant in all these patients. And that remains an important question, and I'll show you some data down the line. Then the Emory University, they have been using VRD induction treatment for a very long time, since 2007. And they had a data set of about 1,000 patients who had VRD followed by autologous transplant, uniformly treated patients. And they did a really smart analysis looking at T1114 versus standard risk non-T1114, that is patients with hyperdiploidy, but without deletion 17p. And they showed the same thing, that patients with T1114, they had slightly worse progression-free survival, which was statistically significant compared to patients who were standard risk non-T1114. And this confirmed the data from Mayo Group, which showed an intermediate risk behavior of T1114 patients. However, in this study, they did not show any overall survival difference, albeit at a short follow-up of approximately 3 years. Now, the next question is that will addition of daratumumab frontline change the natural history of T1114 myeloma? So there is some preclinical data on anti-CD38 monoclonal antibody in T1114, which actually raised some concern that daratumumab may not be a good drug for T1114. So if you see in these preclinical studies, what they showed was that patients with T1114 had a lower CD38 and CD138 expression compared to patients without T1114. Although they did have CD38 expression, but it was lower. Also, it showed that there was a higher BCL2 by BCL2 L1 ratio in patients with T1114 myeloma cells. As we know that marker of sensitivity to BCL, this is a marker of sensitivity to BCL2 inhibitor, venetoclax, on which I'll present some data shortly. So based on these preclinical studies, the question in the field was that does it mean that anti-CD38 monoclonal antibodies would be less effective in patients with T1114 myeloma, given that these patients have a lower CD38 expression compared to patients without T1114? So I'll take a brief segue out of multiple myeloma into AL amyloidosis at this time, because there is some really interesting data coming out of the Andromeda trial in which they did analysis by FISH abnormalities. So just to give a brief summary to the audience on what the Andromeda trial was. So it was a large multi-center global phase 3 trial in which patients with Mayo stage 1 to 3A AL amyloidosis were randomized 1:1 to Dara-Cybody versus Cybody. And patients with the Dara-Cybody, they continued to receive once a month Dara maintenance for a total of 2 years, whereas the Cybody arm had only 6 cycles of Cybody and then stopped, no maintenance at that point. And the primary endpoint was overall hematologic complete response rate. And recently, I think just about a month or two ago, Dr. Kumar and colleagues presented the data on FISH abnormalities from the Andromeda trial. And as you can see, across the board, patients with Dara-Cybody had a higher incidence of hematologic complete response compared to patients with Cybody. But I would like to focus on the T1114 subgroup here. As you can see, the difference in T1114 subgroup was really dramatic. So almost a 4 to 5-fold increase in hematologic CR rate with Dara-Cybody compared to Cybody. And this implies that despite these patients with T1114 myeloma or T1114 plasma cell disorders may have slightly lower expression of CD38, that does not mean that anti-CD38 monoclonal antibodies would not work in them. Actually, the CR rate in the T1114 subgroup was, as you can see, one of the highest, across all the cytogenetic subgroups. So we did this study. Sorry, was there a question?
No question. No.
Oh, okay. Sounds good. So I'll proceed. So we did this study a few months ago. It was published in Blood Cancer Journal. Dr. Mani Mohyuddin from University of Utah was the first author. So we used the Flatiron, which is an insurance claims database in the United States, in which we can go and extract data for patients, including cytogenetic data, treatment data, and also the outcomes, long-term outcomes data. And we looked at almost 1,700 patients with relapsed refractory multiple myeloma at second line of therapy or beyond. The reason we could not look at newly diagnosed patients was because the use of anti-CD38 monoclonal antibodies in newly diagnosed setting is just picking up. So there is still not enough data in the insurance claims database on those patients. And we wanted to look at whether T1114 patients are still behaving like an intermediate risk phenotype, that is slightly worse outcome compared to the standard risk patients. And we found that there was no difference in PFS and OS between T1114 positive versus T1114 negative patients. And there were similar results even after excluding patients with high-risk abnormalities. We also found that there was a lower incidence of chromosome 1q abnormalities in T1114 patients, although unlike the Mayo Clinic study where it was none in about 28 patients, in our study, we found that it was actually 25% of patients did have chromosome 1q abnormalities on FISH in T1114 subgroup, versus 30% in non-T1114. And this difference was almost trending towards the statistical significance. So the conclusion from our paper was that patients with T1114 relapsed refractory myeloma do not have an adverse risk when treated with anti-CD38 monoclonal antibody-based regimens. Now, so there are some important caveats. Obviously, this is a retrospective cohort study. There was lack of a control arm in which patients were treated without anti-CD38 monoclonal antibodies. And we really need secondary data from clinical trials of these using these agents to look at how T1114 patients are behaving when treated with anti-CD38 monoclonal antibodies in myeloma. So putting it all together, the question is, what is the prognosis of T1114 subgroup in the current era when we have anti-CD38 monoclonal antibodies, PIs, IMiDs, autologous transplant, and also some cytotoxic agents? So I found a really fascinating evolution of T1114 prognosis. So if we go in the initial era prior to PIs and IMiDs, there was no adverse impact on PFS and OS when detected by FISH in the era of cytotoxic chemotherapy plus minus transplant. Then if we go to figure 2 here on the screen, which is in the era of VRD followed by transplant, and this is the data from the Emory group, T1114 behaved like an intermediate risk. That is, their outcome was worse compared to standard risk patients. And then the most recent era of anti-CD38 monoclonal antibody-based quadruplet induction, we unfortunately don't have any data in the frontline setting, but based on the data on the relapse setting, it seems like that maybe T1114 patients are now behaving again as standard risk and not like an intermediate risk. That is, their outcomes have improved with the addition of anti-CD38 monoclonal antibodies. Again, we don't have very definitive data in newly diagnosed setting, but this is just a hypothesis generating study, and we really need to generate more data in the newly diagnosed setting to see if that is true. So now I'll switch gears and go to relapsed refractory T1114 plasma cell disorders, and I will focus a little bit on the role of venetoclax because that's the most exciting thing that's happening in this area right now. So again, I'll briefly introduce another case I saw in clinic now over 2 years ago. So this is a patient who was diagnosed with multiple myeloma originally in an outside hospital in July of 2019. And at that time, patient had received bortezomib, len, and dexamethasone or VRD for 4 cycles, and then proceeded to autologous transplant. He was at that time about 73 years old, so and was very frail. So he was given melphalan 140 and not melphalan 200 in October 2019. And then after transplant, he was in a complete remission with MRD negativity by flow at 10⁻⁵. And at that point, patient started on len maintenance. However, he had really bad adverse effect to len maintenance, including grade 3 cognitive impairment, failure to thrive, severe diarrhea, so had to be switched to ixazomib maintenance at that time. But unfortunately, shortly thereafter, he had an aggressive clinical relapse. And the clinical relapse at that time actually was T1114 positive, but also deletion 17p positive, which made sense because had a really quick relapse after autologous transplant. And he had several comorbidities, including atrial fibrillation, heart failure with reduced ejection fraction, EF of 40%, and as I just alluded to, had severe fatigue, diarrhea, and cognitive impairment with lenalidomide. So now I'll take a brief segue to talk about venetoclax before we come back to the case to see what happened to the patient. So venetoclax, as we know, is an oral BCL2 inhibitor. So it's a BH3 mimetic, which it's an orally available BH3 mimetic, which is an endogenous antagonist of the anti-apoptotic protein BCL2. And it has clinical activity in, of course, in CLL, in acute myeloid leukemia, and also high-risk MDS. And as we know, in non-Hodgkin lymphoma, TPLL, BPCD, and T1114 myeloma. In preclinical studies, it has been shown that dependence of T1114 multiple myeloma cell lines on BCL2 for survival. And we exactly don't know why that is, because T1114 is not a BCL2 translocation, but it has been shown in multiple studies that patients with T1114 or T1114 myeloma cell lines, they are highly sensitive to BCL2 inhibition in vitro. So based on this encouraging preliminary data, one of the biggest randomized trials that was done on venetoclax in myeloma was the Bellini trial. And I wanted to briefly touch upon the Bellini trial because there are some lessons to learn from this trial. So just for the audience, a brief summary of the Bellini trial design. So patients were randomized 2:1 to venetoclax bortezomib dex versus placebo bortezomib dex. Now, it's important to remember here that this was an unselected population. So although we knew that venetoclax has a higher activity in patients with T1114, unfortunately, the trial was designed in an unselected population, including patients who were all comers, irrespective of the presence of T1114. And also important to note that the control arm was suboptimal. Typically, bortezomib dex is not a regimen that we would use in a relapsed multiple myeloma in the US, or actually in many parts of the world. So these are important caveats, and we'll see what the results were in the next slide. So there was a surprising signal of increased death with venetoclax in this trial. So if you see on the top, which is the PFS or progression-free survival, the progression-free survival actually was superior with venetoclax compared to placebo. Hazard ratio was 0.63, but at the same time, there were higher deaths in the venetoclax arm compared to the placebo arm. And this trial was actually halted early because of that, because of the higher death signal in the venetoclax arm, unfortunately. But if we look at the T1114 population, the PFS signal was much more pronounced. You can see early separation of the PFS curve with venetoclax being clearly superior compared to placebo in T1114. And if you look at the overall survival in T1114, there was actually no difference, and it was a very small number of patients. However, based on this trial, we cannot definitively make a conclusion that venetoclax is superior to placebo in T1114 because of a few reasons. That number one, this trial was not powered to answer this question. The T1114 subgroup was very small. And number two is that the subgroups may not have been balanced properly. And the interaction coefficient was not provided, to my knowledge, in the paper, the subgroup interaction coefficient. But as you can see, I mean, overall, there was not an increased signal of death in the venetoclax arm compared to the placebo arm in T1114. And the PFS, the magnitude of the PFS difference was really profound. Subsequently, there have been several phase 1 and phase 2 studies which have come out in the past 2 or 3 years. Some of them in T1114 only population, some of them in unselected population, including both T1114 and non-T1114 patients. And just to mention that after the Bellini trial results, FDA mandated that all subsequent trials of venetoclax in any plasma cell disorder, not only myeloma, have to occur only in T1114 patients, not in all comers, which makes sense because it has activity only in T1114 subgroup. So these are some of the regimens, including Vendex, bortezomib dex, venetoclax, bortezomib daratumumab dex, a quadruplet, venetoclax, carfilzomib dex, and venetoclax daratumumab dex. And as you can see, the VGPR or better rate, and here we are not talking about overall response rate, that is PR or better. We are talking about the deep responses, VGPR or better rate. It was highest with venetoclax daratumumab dex, almost 95%, which is really good compared to some of the other VGPR or better rates with the triplets in multiple myeloma that we see. And venetoclax carfilzomib dex was also close, was 85%. As you can see, the venetoclax bortezomib daratumumab dex, despite being a quadruplet, the VGPR or better rate was not superior than some of the other triplets. Again, speaks to the fact that bortezomib may not be as effective in patients with T1114. And of course, single agent venetoclax dex had a VGPR or better rate of 37%. 6% in T1114. Some of the important toxicity signals that were seen in this trial was that grade 3 or higher infection-related adverse events was in the ballpark of 25 to 35%. The most common infections were URI and pneumonia. In the Venn-Dara Dex, despite a very high efficacy, there were actually no treatment emergent deaths, and there were no PJP, but rare fungal infections were reported in some of these trials. So we wrote this paper last year in British Journal of Hematology on how we manage T1114 plasma cell disorders with venetoclax, and with the caveat that venetoclax is still off-label, and we usually consider it only in later lines, mostly, and very rarely in earlier lines of treatment, like first relapse, for example. However, we kind of developed a framework based on the currently available data that in patients who are either IMiD refractory or PI refractory, probably daratumumab with venetoclax or dex would be the most appropriate regimen given the high VGPR rate in the phase 2 studies. Similarly, patients who are dual refractory, in patients who are anti-CD38 antibody refractory, perhaps venetoclax Kyprolis dex or venetoclax carfilzomib dex would make the most sense given the higher response rate with this regimen with a reasonable safety profile. With triple class refractory, although we said venetoclax dex, but with single agent venetoclax dex, as you know, the VGPR rate is only about 36%. So these patients clearly remain an unmet need still. And this paper was actually written before the BCMA targeted therapies were approved, but now, with the arrival of teclistamab, for example, which is a BCMA bispecific antibody, and 2 BCMA CAR T cells, including ide-cel and cilta-cel, it remains unclear how venetoclax will be sequenced, with the arrival of these regimens. Another important study from Dr. Samir Parekh's labs at Mount Sinai that was presented last ASH, that patients who have T1114 and gain 1Q, they actually have a poor progression-free survival compared to patients who have T1114 without gain 1Q. And again, this needs to be validated in larger studies, but this kind of mirrors some of the anecdotal observations that we see in the clinic, that patients who have concomitant T1114 and 1Q, the response to venetoclax isn't great. And even if they respond, they usually relapse very quickly. The PFS hazard ratio in patients with T1114 plus gain 1Q in this small retrospective study hazard ratio was 5.4. Also, they identified a signature of 6 genes that can predict for a response, and that definitely needs additional validation before incorporation into clinical practice. So back to our patient. So some of the important things that I typically think about when a patient is relapsing on lenalidomide maintenance or ixazomib maintenance, for example. We don't use ixazomib maintenance as much anymore, given the data which has come out in the past 2 years that it's not very effective. But basically in this patient, what are they relapsing on, or the refractory status? So this patient was relapsing on ixazomib. So we would not like to use something like bortezomib because patients who are ixazomib refractory, would unlikely that they would respond to bortezomib. Then the next question is, do prior toxicities preclude certain therapies? Now, this patient had a really bad toxicity with lenalidomide, including severe cognitive impairment, diarrhea, and fatigue. So we were a little bit nervous with using pomalidomide, although it's not a complete contraindication, but we were a little nervous given the side effects with len. Then the other is, do comorbidities preclude certain therapies? So we definitely wouldn't want to use carfilzomib with this patient, given he has atrial fibrillation with intermittent rapid ventricular rate, and also had heart failure with reduced ejection fraction. No, that's okay. Yeah, I'll continue. So, and the heart failure with reduced ejection fraction. Then the next question is that is high-dose melphalan autologous transplant an option? We always consider transplant and relapse if the duration of remission with first transplant is more than 3 years. But this patient unfortunately had a duration of remission of less than 2 years, so it's unlikely. And also, given that he was 77, almost 75 years of age at that time, he would likely not be a good transplant candidate. Then the next question is the patient refractory to anti-CD38 monoclonal antibody? If not, then the preferred regimen should always be an anti-CD38 monoclonal antibody-based triplet. And finally, the T1114 status, because if the patient is T1114 positive, always think venetoclax as an option. And again, we still don't have the FDA approval for that, and we tend to use mostly in later lines or relapses, but always think about venetoclax as an option in early relapse in case there is contraindication to use some of the other agents. So in this patient, we actually ended up using daratumumab venetoclax dex instead of using daratumumab pomalidomide dex, given the patient was not willing to try another immunomodulatory drug with the side effects that he had had with lenalidomide before. And we did not use a ramp up. So unlike CLL, we don't use a venetoclax ramp up because the risk of tumor lysis syndrome is very low. So we started the patient on venetoclax 400 milligram and dexamethasone on 20 milligram with no ramp up. He achieved a stringent CR with MRD negativity on flow at 10 power minus 5. The only major toxicity he had was a C. diff infection, which resolved with supportive care. His duration of remission on this regimen was 14 months, so slightly more than 1 year, following which he experienced relapse. And then at that point, he was transitioned to a phase 2 clinical trial of a BCMA bispecific antibody, to which he achieved a stringent CR with an MRD negativity after 1 month. And currently at 8 months in the phase 2 trial, he remains on stringent CR with treatment and with a good quality of life. So now in the last few slides, I'll switch gears to a topic which is really close to my heart, is systemic AL amyloidosis, and T1114 being a very common cytogenetic abnormality in systemic AL amyloidosis. So again, I'll introduce a case which I saw when I first started in Colombia about 2 years ago now. So 65-year-old female with T1114 AL lambda amyloidosis had a really severe heart, GI tract, and kidney involvement and diagnosis. She was started on Darasibody as per the Andromeda trial. So just a side note that T1114 is present in about 50 to 60% of patients with AL amyloidosis, unlike in multiple myeloma, where it's only about 15 to 20% of patients based on what study you look at, but it's much more common in patients with AL amyloidosis. So after 3 cycles of Darasibody in this patient, the lambda free light chain dropped from 50 milligrams per deciliter to about 35 milligrams per deciliter. So it was not a 50% reduction and plateaued thereafter. So as we know that this is not an adequate response in AL amyloidosis, and we really would want to achieve a hematologic complete remission with preferably the involved free light chain of less than 2 milligrams per deciliter. At that point, she developed worsening congestive heart failure and bilateral pleural effusions. The NT-proBNP increased from around 2,000 picograms per ml at diagnosis to about 5,000 picogram per ml after 4 cycles. She was obviously not a candidate for transplant at that time due to elevated cardiac biomarkers. She would be at a very high risk of transplant-related mortality, and also because of her performance status overall. So what does T1114 mean in systemic light chain amyloidosis? So historically, in several studies, and I have put up one study here from the German group, but even data from Mayo Clinic has shown that T1114 usually predicts for a poor outcome in patients with systemic AL amyloidosis in the era of Cy/Body-based chemotherapy, that is prior to the arrival of daratumumab. And as far as hematologic complete response rate is concerned, it seems that Darasibody, or the addition of daratumumab, has completely abrogated the negative prognostic impact of T1114 in AL. However, long-term data on hematologic event-free survival and overall survival are still not available, and we need to wait for those data. But at least from the CR rate standpoint, it seems like the adverse prognostic impact doesn't exist anymore. And approximately 40% of patients still, even with Darasibody, they do not achieve a CR. And that's not only in T1114, but also in the other cytogenetic abnormalities. So as you can see, these Kaplan markers on the right side, both for event-free survival and for overall survival, patients with T1114 had a worse outcome compared with patients without T1114. And this was primarily the era of most patients received either bortezomib dex or Cy/Body, Cytoxan bortezomib dex. So this is a multi-center retrospective study that was led by Columbia, actually. Before I started here, it was led by one of our fellows at that time, Dr. Prem Kumar, and Dr. Lench, who is our director, who is the director of our program, along with Mayo Clinic and several other centers, where they looked at how venetoclax works in patients with relapsed refractory T1114 AL amyloidosis. And caveat, this is retrospective data, but you can see there was a clear demarcation between T1114 and non-T1114. In patients with T1114, the VGPR-CR rate was almost 80%, which is unprecedented. Whereas in patients with non-T1114, it was only about 30%. So almost, I would say, more than a twofold, almost a threefold increase in VGPR-CR rate in T1114 compared to non-T1114, similar to the data that we have seen in other plasma cell disorders. And the responses were also much more durable in T1114 compared to non-T1114. The red curve here is T1114 and the blue curve here is non-T1114. So basically in the non-T1114 patients, even though some of them responded, they relapsed quickly or the responses were not durable. So this is a phase 1/2 randomized trial that we are leading from Columbia currently on venetoclax using this preliminary data. So we actually have had the first patient accrue last week on this trial. So currently the phase 1 dose escalation part is ongoing, where we are testing 4 doses of venetoclax in relapsed refractory systemic AL amyloidosis. And after that, there'll be a 1:1 randomization to venetoclax dexamethasone versus investigator's choice chemotherapy. And the primary endpoint is VGPR or better rate. Given AL amyloidosis is such a rare disease, it was very difficult for us to power the trial for some of the long-term outcome, for example, progression-free survival or overall survival. So we will primarily be looking at a greater than equal to VGPR rate. We'll, of course, track progression-free survival and overall survival as some of the key secondary endpoints in this trial. So we will see if this trial is successful. And FDA currently has, because of what they saw in the Bellini data, that is, there's a higher death signal with venetoclax in non-T1114 patients. FDA, which I think is a good step, is mandating that venetoclax go through randomized design, even in rare diseases like AL amyloidosis, in relapsed refractory setting, before moving it into the upfront setting, or even in T1114 patients, or before approving them. In myeloma, as we know, several randomized trials are currently ongoing. And in AL amyloidosis, there is this one, the venetoclax dex, and there is another trial, the altitude trial, which is daratumumab venetoclax dex, that will also open soon. So back to our patient. So basically, as soon as we started venetoclax dexamethasone, that is when the lambda light chain was roughly around 30 milligrams per deciliter, you can see there is a rapid drop in the lambda light chain, and she achieved a quick hematologic complete remission. And at the same time, there was a decrease in the NT-proBNP to almost, you can see, normalization of NT-proBNP around 400 picograms per ml. And it has been almost 2 years now. She remains off treatment in a hematologic complete remission, and with a good cardiac response and with markedly improved quality of life. So at Columbia, our approach to relapsed refractory patients with AL amyloidosis is primarily based on the T1114 because of such efficacy of venetoclax in T1114 patients. So if patients who are relapsed refractory or have a suboptimal response to frontline therapy after Dara-Cybar-D, we check for T1114. If T1114 is present, we usually give those patients venetoclax. And depending on whether they had a myeloma-like phenotype or a high-risk phenotype at diagnosis, we strongly consider high-dose melphalan autologous transplant if they are eligible for that. The other options are listed here, including IMiDs or reuse of anti-CD13 monoclonal antibody. Those are in rare situations. For example, if patients are relapsing, let's say 4 or 5 years after Dara-Cybar-D, maybe in those situations, just reusing daratumumab will do the job. It's hard to know, but we usually go for venetoclax first, preferably in a clinical trial. If they're T1114 negative, then of course we have limited options in AL amyloidosis. We consider IMiDs, reusing prior regimens, and in those patients, if they're eligible, we actually strongly consider autologous transplant right away if patients are eligible for that and it's safe to do so. I have one slide on T1114 primary plasma cell leukemia. I know we are almost closing up on time. So primary plasma cell leukemia is also a fascinating entity where T1114 is present in approximately 50% of patients. So this is actually one of the largest cohorts of primary plasma cell leukemia that was published by the French group recently. And they looked at the cytogenetic abnormalities in patients with T1114 compared to those without T1114. And they found that patients with T1114, they had a lower incidence of chromosome 1 abnormalities, a lower incidence of deletion 17p, which we have also seen in some of the other studies, and also a lower incidence of double hit patients, that is, those with 2 or more highly cytogenetic abnormalities. And also they did better as far as progression-free survival is concerned. You can see that there is, actually this is an overall survival curve. You can see there is a very early separation of curve, that patients with T1114 actually had a better overall survival compared to patients without T1114. And there is currently a clinical trial under design by the cooperative groups in the US of in patients with primary plasma cell leukemia, where there will be stratification up front, and patients with T1114, it's not a randomized trial, but will be stratified, and patients with T1114 will have venetoclax incorporated with the upfront regimen, and to see whether addition of venetoclax can improve the outcome of these patients with T1114 primary plasma cell leukemia. So with that, I would like to thank everybody for their attention. I'm happy to take questions. I would like to acknowledge our Columbia Multiple Myeloma and Amyloidosis program, which is really a multidisciplinary group, including not only hematologists, but also our advanced heart failure group, who help us with managing patients with AL amyloidosis. our nephrology group, Dr. Radhakrishnan, who is a world leader in glomerular diseases, our bone marrow transplant group, our cardiac pathology and renal pathology groups, and our funders. And finally, I wanted to put a plug for our podcast, Blood Cancer Talks, which two of my colleagues, Dr. Kishtagari and Dr. Cliff and myself, we have started last year, and we focus only on topics related to hematologic malignancies. So would really appreciate if you guys check it out. With that, I would like to end, and I'm happy to take any questions. Stop sharing.
Thank you so much, Dr. Chakraborty. That was fantastic. We have not had a dedicated talk on this subject, which you have delivered today. With all the data, it was very interesting. So our colleagues are here. I'm sure they will have some questions. You can use raise hand sign. You can open your videos, chat with Dr. Chakraborty. To begin with, maybe I can ask you one question. In myeloma setting, so in a newly diagnosed patient, is there any importance of looking for 11-14?
So in newly diagnosed, currently it is not changing the practice because we are not using any drugs like venetoclax in newly diagnosed setting. However, I would say that in patients who present with light chain myeloma only, with cast nephropathy, with very high light chain burden, I think it's important to know, because in those patients, we really need to bring the light chain burden down as quickly as possible for hopefully renal recovery. And we know that those patients don't have good response to regimens like Cybody, like bortezomib-based regimens. And many times we cannot give them IMiDs because their creatinine is high. So in those patients, basically, I think it's important to know if they're T11-14 because then we use daratumumab early.
Sir, good evening. Good evening to everyone.
Please mute yourself.
Sir.
Yeah, thank you.
Yeah, so in those patients, we typically use daratumumab early.
Please, Sudhir,
Sir, my question.
Keep yourself muted. We'll come to you. We'll ask you the question afterwards.
Yeah, other than that, I think maybe it's okay to not check for T11-14 at diagnosis because it's not going to make any big difference currently.
And as against that, in plasma cell leukemia and amyloidosis, yes, you would like to do that, right?
In amyloidosis, for sure, because in amyloidosis, there is a hurry that we really want to achieve hematologic CR as quickly as possible, as you know, because there is ongoing cardiac damage going on. And we usually what we do is in our institute and in most amyloid centers that if patients do not achieve a partial response by end of cycle 1 with Cybody, we like to switch early. And if they have T11-14, then if they are eligible for a trial, that's fine. But if they're not eligible for a trial, then getting venetoclax can take time. We usually ask the company to provide it on a compassionate basis because it's not FDA approved, so insurance may not cover it. So if we know that patient has T11-14, we already get it in the first 1 or 2 months in case we need to use it down the line. If we don't need to use it, that's fine. But in amyloidosis, we definitely check upfront for T11-14 just to be prepared in case we have to use venetoclax.
Right. So we have a question in the chat box for you. Can BCL2 positive on IHC be used as a predictor of response to venetoclax?
Actually, no. So BCL2, so in the Bellini trial, they did show that BCL2 expression was a predictor of venetoclax benefit but however, that was based on the gene expression profiling. So it was not based on immunohistochemistry. The problem with IHC is that most patients with myeloma are going to be BCL2 positive, and there is no standard cutoff or standard guideline as to what percentage we would use. So BCL2 IHC, actually, I think Dr. Shaji Kumar said that specifically in one of his talks last year. I heard that BCL2 IHC should not be used as a marker for venetoclax use in myeloma or AL amyloidosis. It should be, because the gene expression profiling test, we don't have it available in clinical practice. So it should only be T11-14 that should be used.
Right. I have one question regarding the dose, 400 mg, which is standard. We find, at least in India, in myelodysplastic syndrome and AML, continuing 400 mg has been very difficult. There's a lot of myelotoxicity. Is that there in these patients of amyloidosis and myeloma?
Yeah, I have also heard from my colleagues who do AML MDS that it's really hard to tolerate. But in myeloma and amyloidosis, 400 milligram, we have not found it hard to tolerate. In some of the initial trials, they have actually used up to 800 milligram, and that caused some of the infection and the infection-related deaths. So The current trials, from what I heard from the company, will do 400 as the maximum dose. So in clinical practice, in amyloid, I usually do 200 because those patients have a very little tumor burden, so they don't need a lot of, even with 200, they can achieve a complete remission most of the time. In myeloma, I usually do max 400. I don't go above 400. I have seen some thrombocytopenia sometime with 400 that I had to decrease to 300 or 200, but I have not seen a lot of other toxicities. So 400 is pretty reasonably tolerated.
And you have to look for 11-14 by fish in amyloid in the plasma cells in the marrow. Is that the only? That's the
yeah,
only...
by CG138 selected fish. Yeah. Mm-hmm.
Another question has come up in the chat box from Dr. Bhausaib. Thanks for a comprehensive review. Whether you will consider when in relapse refractory myeloma without 11-14 translocation, any biomarker like B cell markers by IHC or flow will guide you. And again, same thing, BCL2 profiling, whether it will help you.
Yeah, so for other than T1114 from the Emory group, they had a paper in which they identified a flow, a particular flow positive signature that can predict for venetoclax sensitivity. For example, CD20 positive. However, the problem is that is not validated yet, and most centers, it's not a standard profile that I can order. So sometimes what I do is if a patient is T1114 negative, I usually ask our pathologist to run those particular flow markers that was shown in the Emory group and see if those are positive, and they have a score that you can get based on that. However, I don't think it should be routinely used because we had seen a death signal in venetoclax trial in non-T1114 patients. So I think that's why we should be really careful using venetoclax in non-T1114 until we have really validated markers, because we don't know, maybe we might be harming patients by using in non-T1114 patients. So I other than T1114, I usually don't use other markers in routine clinical practice to use venetoclax.
Is there any data on monotherapy venetoclax?
Yeah, there is some data. The initial trial that was done by Dr. Shaji Kumar that had a 40% response rate, VGPR or better, in T1114. Overall was much lower, but in T1114 was about 40%. I think Dr. Soni has a question in the chat on what is the effect of having high-risk translocation. It's a very interesting question, and we have been struggling because there is no clear data yet on what is the so the question is that whether venetoclax works the same in patients with T1114 plus high-risk abnormalities versus T1114 without high-risk abnormalities. And the answer is we don't know. However, as I showed in one of the slides with Dr. Samir Parekh's lab from Mount Sinai has showed that patients who have T1114 plus 1Q, they usually don't respond well to venetoclax. So even within T1114, there is heterogeneity. With those with T1114 plus deletion 17p, like my patient that I presented, he responded well, but he relapsed at 14 months, so the PFS wasn't great. We don't have systematic data on that, and that is something that I think we need to look into the charts to get more data in future. And in general, we know that patients with T1114 with high-risk translocation, they do slightly worse compared to T1114 without high-risk translocation in a global setting, irrespective of treatment.
Dr. Akash Khandelwal, your question. Till he asks his question. There's another question.
There is a question here that any benefit of incorporating chemo-based protocol over targeted chemo in relapse refractory. Yeah, that's an interesting question. I think the main clinical question in front of us is in patients with relapse refractory T1114, whether we should use, after we run out of our usual medications, right? Like pomalidomide, carfilzomib, daratumumab, whether we should use venetoclax first, or whether we should use, because in US now we have BCMA approaches also like Tecvali and Idacel and Cilta-cel, or whether we should use BCMA first. And that, I think we don't know the answer to that question. Now, whether we should use chemo-based protocol, I mean, in some of these patients, when they're aggressively relapsing, I do use like VD-PACE, for example. However, we don't know whether that is superior to using something like venetoclax-based triplets or using BCMA-based approaches. And we just don't know the answer to that. It's a very, very good question.
Dr. Sinbin has put a question. It's from, again, AML MDS, where we use voriconazole, etc., to reduce the dose of venetoclax. Venetoclax being an expensive drug. But the same can be done in your patients of plasma cell dyscrasia.
Yeah, so I have heard from some of my colleagues in Mexico that they have done that also. However, the thing is, in myeloma patients, usually they don't need fungal prophylaxis because the risk of fungal infection is very low. And even with venetoclax, I think the risk of only one study showed maybe one patient of aspergillosis, but it's very low. Like we don't use it as often. If you want to reduce the dose by using antifungal prophylaxis in a high-risk patient, I think it's okay, especially if you think the patient may be at risk of fungal infection. I've heard some people do that, but in myeloma, it's just that most patients don't have the indication to use an antifungal.
Dr. Panda, your question.
Good evening, sir. Sir, an excellent talk, sir. Thank you. So, hello, am I audible, sir? Hello?
Yeah.
Okay. So, sir, actually, I joined a little bit late. So, can you explain what is the biological plausibility behind adding venetoclax in translocation 11-14? So, what is the biological plausibility that may influence this addition of venetoclax and especially its efficacy in this particular subcohort of myeloma patients?
Yeah, so from my understanding of the literature, it was a little bit accidental discovery. Like it was not really, because the T1114 is a translocation between cyclin D1 and immunoglobulin H. So it's not a BCL2 translocation. But in the initial preclinical studies, it was discovered that patients with T1114, for some reason, they are very sensitive to BCL2 inhibition. Now, why that is, I don't know. It's at least from my reading of the preclinical studies, why T1114 is sensitive to BCL2, although there is no BCL2 translocation. I'm not sure. I think the reason is that most T1114 patients, they have a slightly immature phenotype. So they are kind of between lymphoma and myeloma. They have lymphoplasmacytoid cells, scant cytoplasm, low M protein, and they're slightly immature. And we know that, most patients with B-cell non-Hodgkin lymphoma, like a large proportion of those patients, they have sensitive to BCL2 inhibition. For example, Waldenstrom, we know that they are very sensitive to BCL2 inhibition. So it's possible that because of that, but at least from my reading of the literature, there is no strong reason so far. It was more of a serendipitous discovery that venetoclax really works well, and they are very sensitive to BCL2 inhibition.
The CD20,
okay, sir. Thank you.
CD20 positivity is almost uniformly there?
No, so CD20 positivity in T1114 is about half or less than half of T1114 patients. And that's what the Arkansas group showed, that there are CD1 and CD2 subtype, and only the CD2 subtype had CD20 positivity. And I think one thing that I always think about in clinic is maybe drugs like CD20 bites, that we have in lymphoma now, will those be effective in CD20 positive myeloma? I don't know, but it's an interesting, thing. And maybe once they exhaust all treatments and we have no other option, maybe we can use that and see if those work. Interesting.
There's no data on simple rituximab.
There's no data. No.
Akash, you want to ask any question?
Yes, sir. Yes, sir.
Yes, sir. Go ahead.
Hi, sir. Excellent talk, sir.
Thank you.
Sir, a few questions specifically for amyloidosis. First is, sir, what is the expected duration, the response time of venetoclax? And what do you add in a relapsed refractory amyloidosis, AL amyloid 11-14? And the plan of action after achieving a response, a VGPR or PR is enough for going to the transplant? And also, do you consider a maintenance venetoclax post-transplant?
Yeah, those are very, very interesting questions. And so basically, to answer your first question, then what is the long-term plan? So let's say if we start a patient with relapsed refractory amyloidosis on venetoclax, how long should we continue it? And in our trial that we are doing, we are giving venetoclax for 6 cycles. So 6 months and stop, so fixed duration. However, that was not, I would say, a completely scientific decision. That was a decision based on the amount of money we were given by the company. So they were not willing to fund until progression. So that kind of a decision had to be made because of the financial aspects of it. But in our practice, we have been mostly using at most 6 months, or some people are using up to 1 year. So nobody is using until progression. And so far, at about 2 years of follow-up, after stopping venetoclax, we have not seen relapses, like light chains going up. We have not really seen. Now, we don't have very long-term data, of course. And in our trial, we will capture long-term data that after 6 cycles, what is the rate of relapse? So I would say in patients with AL amyloidosis, because they are very frail and we don't really want any bad infection like pneumonia in them, because they can die if they have a really bad cardiac status and have a really bad pneumonia. So I would say 6 months to 1 year is the maximum duration of venetoclax we should use. We shouldn't use more than that. And once they achieve a CR to venetoclax, we are usually not doing autologous transplant in them. We are only doing if they're not achieving a CR, because if autologous transplant, as you know, in AL amyloidosis is associated with mortality, like up to 5%, even in carefully selected patients. So if they already are in a complete hematologic remission, then why to take the risk of that, transplant-related mortality? So we are not doing transplant in those patients.
So even after relapse, you're not considering it as a
even after relapse, because many of these patients are not eligible for transplant, like they have a high NT-proBNP, they are in their 70s, or they are, if somebody is really fit, and completely eligible for transplant, you can consider it. But I will tell you that most patients with amyloidosis, when they hear about the risk of transplant-related mortality, they don't agree for transplant if they are in a CR. Of course, if they're not in a CR, they will agree. But if they're in a CR, then they are usually very scared to go through the transplant process at that point.
Answer, what is the added drug that you use with venetoclax? The dexamethasone?
So yeah, in amyloid, we usually use dexamethasone 10 or 20 milligram, not more than that, once a week. Now, there is another trial that will open soon of venetoclax, DARA, and dexamethasone, so triplet in AL amyloidosis in relapse. Now that would be good if, let's say, a patient is relapsing 5-6 years down the line. But we are using DARA-CyBody here in the US in frontline. So if, let's say, the patient is refractory to DARA-CyBody, then it would not make sense to add DARA, because they already just saw the DARA. But if somebody is relapsing after 5 years, then I think that triplet regimen would make sense. One concern I have is with that regimen is the infection again, because I have used that regimen in a few patients, and I had one patient who was actually admitted with multifocal, like a really bad pneumonia, was in the ICU, thankfully survived, but because both DARA and venetoclax are very immunosuppressive when used together.
Right. Answer, what is the expected timeline for CRs? You expect 6 months only is the standard, or you expect a sooner response rate?
Very sooner. So we are seeing a time to response of roughly about 2 to 4 weeks. We will be capturing that data in our trial, but in real world, I have been seeing, because I have been checking light chains like every 2 weeks in the first 2 months, and even in 2 weeks, I've seen light chains completely normalizing in some patients. So it's a very quick response usually.
And 28 days is the cycle time?
Yeah, continuous. Yeah, 28 days.
28 days. Okay. So no maintenance, because you are not transplanting anyways. So yes.
Yeah,
no data is there on that.
There is no data on maintenance in amyloid, as you know, and even if we are even in patients who are undergoing transplant, post-transplant, we are not doing maintenance. We just watch and wait with every 3-month lapse. That's it.
Right, sir. One more question. Does it have an impact on cardiac amyloidosis per se? Because in your case, you mentioned the NT-proBNP, everything went down. So what's your take on that? Is it really helpful that way? And
sorry, go ahead.
Even some patients are having cardiac symptom post-transplant also, should we consider in some of them like that if they are a very severe cardiac dysfunctions? I'm not really sure on that.
Also venetoclax doesn't have directly any impact on cardiac function. It's mainly the light chain. So once you normalize the light chain, like I had some other patients too, which I didn't show, in whom the 24-hour urine protein went down to normal. So it's basically the light chain. So if the light chains you bring down to normal, then over time, the heart and the kidneys will improve in 50 to 60% of patients. So as you said, after transplant, if patients still have not achieved a cardiac response, if they have a high light chain and T1114 positive, I would use venetoclax. But if the light chain is normal, then venetoclax will not do anything, because light chains are already normal, so it wouldn't make sense to do.
So it's an indirect effect, not the direct effect on the cardiac.
Not direct effect, yeah.
Okay. Thank you. That's all.
No problem.
A lot of queries.
Really interesting discussion, yeah.
Thank you.
Thank you, Akash. Dr. Panda, you have more questions.
Yes, sir. So I have, sir, one doubt actually. So what is your practice in as far as maintenance is concerned in high risk multiple myeloma? Because there was a paper in Blood Advance recently. They have mentioned lenalidomide works exceptionally well in those cohort of patients, especially in deletion 17p and TP50 deletion 17p, 1Q gain, and one more paper in I think Cancer Journal has been published this month only. They have shown that bortezomib lenalidomide is equivalent
Yeah,
It is
yeah.
equivalent, and there is no added advantage of bortezomib. So, are we shifting towards lenalidomide maintenance even if in high risk multiple myeloma? So, what is your take, sir?
Yeah, so that's, we have been struggling with what maintenance to use for a long time, right, in high-risk myeloma, because there is no good data. So what we do is we definitely do lenalidomide maintenance in everybody, because that has been shown to have overall survival benefit, right? So irrespective of their high risk, standard risk, we use them. In high risk, in the US, there have been a practice of doing a dual maintenance, like lenalidomide and a PI, either bortezomib or carfilzomib for 2 years. However, that is not based on really strong data. So we do it, but we tell the patients that the data is not there that it improves overall survival. Maybe it does. Now with this paper that you just mentioned, the CIB-MTR study and some other data that have come out, it's slightly questioning it, that whether we are really improving overall survival of these patients or not by doing the dual maintenance. So I would say that in my practice, I usually do lenalidomide plus a PI only in patients who are ultra high risk, like have 2 or more, like double hit patients, 2 or more high risk abnormalities. And I only
Yes,
use
yes,
the bortezomib for 2 years. I don't use it for forever, but lenalidomide I use until progression. But I tell the patients that we don't have overall survival data on that, and we will see how the field evolves in the next few years. But this is an area where we mostly have been going by expert opinion, but not good data.
Okay, sir. Thank you, sir. So, one more question, sir. Sir, how do you approach cases of CNS myeloma? Is there any specific protocol or specific drugs you prefer for CNS myeloma?
Yeah, I had a couple of patients the last 6 months, and it's a really bad situation because we don't have any good treatments, unfortunately. And so for CNS myeloma, the thing is that if patients are young, then I would say that one of the regimens in the Arkansas group had a abstract or PAC-MED regimen, cytarabine based regimen. It was never published, unfortunately, but there was an abstract in ASH, I think a few years ago, I think 2015 or so. And because cytarabine has some CNS penetration, and I have heard from my colleagues in Arkansas that that regimen does work reasonably well, but the patient has to be young and fit to be able to tolerate that regimen. The patients that I had were in their 70s, so unfortunately, could not tolerate that regimen. But that is one regimen that you can use in young fit patients, the PAC-MED regimen. I would say other than that, the drugs which have CNS penetration in myeloma are pomalidomide. Then bendamustine has some, but not great CNS penetration, and selinexor. But as you know, selinexor is not a good drug, does not have good efficacy. So I would not use it in a patient with rapidly progressing CNS myeloma. Pomalidomide you can consider if the patient is otherwise fit, but many of these patients are sick in the ICU, and when they have CNS myeloma really aggressive. But definitely pomalidomide is something that you should consider if patient can tolerate it. Other than that, unfortunately, these patients don't have good options. I mean, we really need, there is one proteasome inhibitor called marizomic, which is not in the market, but it was being developed. But unfortunately, it is not being pursued by the company anymore. And some people, I've heard from Dr. Hari, who has used it on a compassionate use basis from the company in a patient. So that is something you would consider. One important thing to remember is that high dose methotrexate does not work in CNS myeloma, and it's important because it has a lot of toxicity. And there is in Arkansas they have data, again some unpublished data, that they have used high dose methotrexate and the response rate was almost 0. So high dose methotrexate we should not be using, and to save patients from the toxicities of it.
In the same thing,
Thank you, sir.
cranial radiation.
Radiation we can use, yes, if the patient is otherwise fit, and if it's if CNS radiation is definitely something that we should consider.
Dr. Khushbu, your question.
Sir, I just want to add a single line. Hello.
Yeah.
Even if hello.
Yeah, Dr. Pandit.
Yeah.
Go ahead.
Yes,
Yeah,
yes,
go ahead.
Yes, sir. There is also a recent paper in VJH. They have tried intrathecal thiotepa in patients of CNS myeloma, just published recently, a case series of 3 to 4 patients. So, have you any experience on that? Maybe.
Yeah, no, I don't have experience, but I know that there is data, and also in CNS myeloma patients, if let's say if you're using something like PAC-MED to get them into remission and then proceed to autologous transplant, I've heard from many transplant experts, including Dr. Hari, that thiotepa should be used in the conditioning regimen in that case because of its activity in CNS myeloma. So but intrathecal thiotepa, I don't have any experience. I've never used it. Yeah, that's interesting. It does have some activity, and if you're taking patient autologous transplant, definitely incorporate that in the conditioning regimen.
Thank you so much, sir. Thank you, sir.
Dr. Panda, Dr. Khushbu.
Yeah, good evening.
Hi.
So it was a very comprehensive talk. Mostly, I
Thank
also
you.
missed the initial few minutes. So I just had a question regarding diagnosis. Like usually, maybe if we see 10 myeloma patients, we ask fish for everybody, and maybe 5 to 6 patients do fish at baseline, and we never ever do at relapse. Mostly no marrow also.
Yeah. I think you are muted, Dr. Khushbu. I can't hear you.
Kushu, you got muted. Yeah.
Yeah, sorry. So do you see? Can you hear me now?
Yeah.
Yeah. Can hear.
Yeah. So do you see this what do you call 1114 as a like mutation if it was not present at baseline? Perhaps if it was present at baseline, do you see it disappearing with the clone, or it's
Yeah, no, so
always
since it's a primary cytogenetic abnormality, it's always present. So once present, it's always present. It will not disappear. And if so, we also don't always repeat a fish at relapse if patient already had it at diagnosis. So unlike deletion 17p, which can appear newly at relapse when it was not present at diagnosis, T1114 is present. Once it's present in the MGUS stage, it will always be present if the patient progresses to myeloma or relapsed myeloma because it's a primary abnormality.
okay. And like the other question is, we have a lot of trials which represent the developed countries, like Andromeda, if you see, or what like you use that subcutaneous daratumab and whatever drug you can get. So in our setting, we either don't have the access or the patient cannot tolerate. So even if we start Cybody, some people might have bortezomib intolerance, like they have diarrhea and already have heart failure with amyloid. So may not tolerate bortezomib related diarrhea also. So what are your other go-to drugs when you are not able to give, say, daratumab or bortezomib upfront? Like
You mean,
Len,
yeah.
imid anyway, they don't tolerate, so they are out. So what else do you try?
So in amyloid, right? You're talking about specifically in
Yes,
amyloid, right?
yes.
Yeah. So you're right. Yeah. IMiDs. So basically, in those patients, IMiDs, yeah, as you said, it's very hard for them to tolerate IMiD. However, I would say that pomalidomide is slightly better tolerated than lenalidomide, and we usually use in these patients pomalidomide 2 milligram or even 1 milligram sometime, because they have a small clone, so they don't need like a lot of dose, and usually it's better tolerated than lenalidomide. And other than that, if they're P1114 positive, and let's say if they cannot afford daratumumab, then venetoclax is not very expensive in India, right? It's less expensive definitely than daratumumab, correct? Or it's still expensive.
But like those, but those patients may not be affording.
May not
that
be
also.
afford, yeah. So venetoclax, I would say, would be the other option in that case if they cannot afford daratumumab, and if because I would rather prefer venetoclax over IMiDs because it's much better tolerated in patients with AL amyloidosis. Like up to 400 milligram dose, we have seen really good tolerance in AL amyloid, like with no problem. And you can even get away with the 200 milligram dose because they have a small clone, and you may not need to use, or maybe use every other day to save some save cost.
So those who are not transplant eligible, like say we have melphalan, which is quite cheap. So would you prefer melphalan, and how long would you prefer, like to get response and then stop, or like?
Yeah, melphalan would be reasonable because there is, we know that cytotoxic chemotherapies work well in T1114. So melphalan or cyclophosphamide, would be totally reasonable. And Meldex has a good data in AL amyloid. So I would use for fixed duration. In amyloid, we typically don't use indefinite, unlike myeloma. So I would use up to like 6 to 9 cycles and then stop at that point.
Thanks.
Yeah, no problem. Thank you.
Any other question from the faculty? In practice, do you use DARA for 2 years after DARA Cyber-D?
Yeah, so that's, as you know, I think it's...
Anish sir, I have a question.
Yeah, sure.
Dr. Rajasekhar, is the breakpoint in 1114 multiple myeloma versus 1114 mantle cell lymphoma is same or different? And is there any effect on the outcome of this breakpoint?
Yeah, it's the same to my knowledge. I think CCND1, yeah, the breakpoint is the same. And the effect on
outcome.
You mean the effect on outcome in myeloma or mantle cell lymphoma?
Both. No, sorry, in myeloma. Myeloma because of this 11-14 translocations.
Okay. So basically in the
Sudhir, what you can do after asking the question, mute yourself.
Okay.
Yeah, I think there's an echo. Yeah. So in the era of PIs and like VRD, which is a commonly used induction regimen in India, right? VRD. So in the era of VRD, I would say that T1114 is somewhat like an intermediate risk. So they do much better than high risk patients, but slightly worse than hyperdiploidy patients. So somewhat in the intermediate risk.
Is there any effect of race on the outcome of patients? American, African, Indian, white, Asian, any difference in the outcome depending upon the race?
Yeah, that's there is some data only on African Americans and whites that was published by the CIBMTR that was only in transplanted patients, and they actually found no significant difference, by race. So I don't know in India, do you guys see a similar? Since you guys see a lot of younger patients, right? It would be interesting to see whether T1114 incidence is higher or not in India.
Thank you very much.
The incidence of 11-14 doesn't look to be high in India. We just get it at 12%.
Okay. And Dr. Agarwal, to answer your question about DARA maintenance, I think it's a very interesting question. And the company always designed the trial in a way that they can give DARA for as long as possible because it's more money for them, right? So that's a problem. And now that we are faced with a situation where maintenance was not a standard in AL amyloidosis, but in the Andromeda trial, they're doing DARA maintenance for 18 months. So what we are doing is at 6 months time point, if patients are in a CR, hematologic CR, then I usually discuss with patients that we can continue the DARA once a month as the trial did, but that's going to increase the risk of infection. So if a patient is old, already had one infection, then in those patients, we usually don't do it. If otherwise a very young, fit patient and doesn't really mind, that we are not too worried about the infection risk, then we do it just like the trial did. So there is actually a trial we are trying to design in which we will address, hopefully, this no maintenance versus maintenance, because that's an important question. And patients with amyloid, usually they don't like, indefinite treatment. They are already, the first 6 months is very hectic for them. So it would be good to get rid of the maintenance.
Wonderful. The last question in the question box is from Dr. Vinayak Chikodi. Role of osteoprotogen in multiple myeloma bone disease.
So to be honest, I'm not an expert in that. Actually, Dr. Lench, who is the director of our myeloma program, she does a lot of research on myeloma bone disease in her lab. But I'm not too familiar with the data on osteoprotogen for myeloma bone disease.
Yeah. Any questions? Otherwise, we call it a day. Okay, so there aren't many more questions. Before I hand over to Mr. Sumit Madan for official vote of thanks, on my behalf, I thank you, Dr. Chakrabarty.
Thank you very much.
Accepting the invitation, being with us. Wonderful talk. Thanks.
No, thank you. And it was a really good discussion. I really enjoyed it. Thanks for the opportunity and thanks for inviting me to this.
Sumit, take on.
Yeah. So thank you, Dr. Rajshekhar, for sparing your valuable time. It was a lucid presentation, and I think multiple aspects of managing this malignancy was covered. And there are many good key takeaways from this wonderful presentation. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank all the discussants and participants who have joined us for this webinar. Last but not the least, this series of webinars is possible only because of continuous support from Perfect Square team. So thank you to them. Thank you so much, everybody, and have a wonderful weekend.
Thank you, Sumit and Zydus, for supporting us.
Thank you, sir. Thank you.
Thanks to everybody. Bye-bye. Bye.
Bye.
Thank you.
Have a wonderful day ahead, Dr. Chakrabarty.
Thank you. Bye.
Thank you, sir.
Thank you, Dr. Sari. Thank you. Bye.